So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to this evening's Lung Cancer Living Room. I recognize all the faces in the room, but to those of you online who might be new here, I'm Danielle Hicks. I am Chief Patient Officer at GO2 for Lung Cancer, which is, as I always say, just a really fancy way of saying I oversee a team of amazing humans who help to bring all of our programs, services, and education to you, just like this one in our very own Michelle Zay sitting over there in the corner. For those of you who might not be familiar with this programming, the Lung Cancer Living Room is an expert speaker series held once a month, third Tuesday of every month, where we invite experts to come in and talk about varying aspects of the disease. And tonight, we're thrilled to have Dr. Allen from UCSF. Dr. Allen is new to the Living Room programming, at least to being a speaker at it, so please be kind. And we're really, really excited tonight to be talking about immunotherapy and its impact on lung cancer. I think you guys have heard us in the past, not I think, I know a lot of you have heard us in the past have conversations about immunotherapy. We're going to take a little bit deeper dive tonight, starting with sort of the basics, what it is and how these types of treatments work, and then who it's appropriate for, both in early and late stage, both in non-small cell and small cell lung cancer. So before we get started, as those of you who are familiar know, I could run through a bio and read a really impersonal sort of explanation of who Dr. Allen is, but instead, we like to start off by asking you who you are and why lung cancer is an area of importance to you. Well,
thanks everybody for having me and getting to chat today. So I'm a physician scientist at UCSF. I've sort of dedicated my career both to treating patients with lung cancer and developing new treatments in the lab. It's something that has kind of been a lifelong mission for me and super passionate about. So I'm very excited to spend the time here sharing with you guys.
Thank you, Dr. Allen. And as normal, I just want to remind everybody, feel free to ask questions throughout. Don't worry that a question you might feel only pertains to you, because I can assure you it pertains to someone else. That goes for both the folks in the room and those who might be watching online. Michelle's moderating all of the questions that will come through the online chat. And I want to give a shout out to Larry, who's normally in the room. Larry, we sent your love to everyone and everybody sent it right back. So thanks for signing in online, and to all of you really who are watching online. Please don't be afraid to ask questions as we're having conversations. So I want to start with something very basic. And I guess before we get into immunotherapy, we talk a little bit about just our immune systems and what they're supposed to be doing.
Sure. The immune system's main job is basically to say self versus not self. This is me and this is not me. So you get COVID, that's not me. You get a bacterial infection, that's not me. You get cancer, that's not me. So what we've found over the years is that the immune system is very much designed to find and get rid of cancer. And part of the reason that we have cancer is because the immune system has, not done the job we needed to do.
Yeah, I think you guys have heard us say before, or you've heard docs in here before talk about our immune system, and sometimes those cells that get past our immune system, they live within us daily. Like the opportunity for a rogue cell or a bad cell or a cell that is not you on the regular has the opportunity to bypass our immune system. But for the most part, our immune systems do a really great job of identifying and destroying. And in the case of cancer or lung cancer, it's because, I guess all cancers, right? Would be because our immune systems didn't find it.
All cancers, they've all changed. They all used to be you and they're no longer you. So by definition, the immune system has failed in those cases, which again, I think is why we're excited about immune therapies, is because we can change that balance.
Yeah. So a lot of folks have heard about, either because of the nice job that some of our industry partners have done with direct-to-consumer advertising and the like, have heard about PD-1 or PD-L1. Can you talk a little bit about those?
Excuse me, sure.
Yeah.
So the PD-1, PD-L1 inhibitors, when we talk about immunotherapy, that's about 90% of what we're talking about, especially in lung cancer. These are the mainstay drugs that you're hearing a lot about. These are the Keytrudas, the Tecentriqs, the Imfinzis, and excuse me.
Right.
They're really a central part of how we're treating the vast majority of lung cancer cases. So it's something that, as a patient, you'll have a lot of experience with, and something you'll speak with your physician about in almost every case now.
So if I understand correctly, these are called sort of checkpoint inhibitors, right? And so one side of it might be a PD-1 and one side might be a PD-L1, and I'm going to massacre this description, but and something gets blocked on either side, right? Which is what's disallowing your immune system to activate. And so these therapies that have been developed are designed to sort of uncover, I guess, that inhibitor.
That's exactly right. So when we talk about the PD-1 inhibitors, we're talking about a molecule. I call it, in just an easy term, it's a stop sign. It's something that the tumor has put up, and that tells the immune system, stop. This is a protected site. You shouldn't be active here. Okay, that's what those stop signs are. That's what that molecule PD-L1 is. And the drug is very simple. It just gets rid of the stop signs. With the stop signs gone, now the immune system can come in, and in the right cases, and with patients it really works, it can come in and have a dramatic effect on these tumors. So it's all about this balance and changing the balance to allow the immune system to get into motion.
Yeah. So immunotherapy is not necessarily right for everyone. And I know when they were originally introduced, there was this sort of umbrella excitement in the lung cancer community, particularly with people diagnosed, thinking this is the latest and the greatest, and if I can get my immune system to activate, right? So, and that's not necessarily the case. As we know, lung cancer is incredibly complex. You guys have heard us talk about that here all the time, and immunotherapy is not immune to the complexity. So is there a test? How do we determine who might be appropriate for immunotherapy?
So it's a very important point. Every patient's different, and every tumor is different, and those are separate things. So not every patient's the right patient for immunotherapy, and not every tumor is the right tumor for immunotherapy. We know some tumors respond really, really well to immunotherapy, and the first obvious sign that a tumor is going to respond is if it has a lot of those stop sign markers, if it has a lot of expression of the PD-L1 marker. Those tumors tend to respond really, really well. The patients, strangely enough, who tended to have smoked a lot, heavy smokers, those tumors tend to have better responses to the treatment. On the other side, patients who have some of the driver mutations that I think a lot of people have heard about in this audience, EGFR, ALK, ROS1, for reasons we're still trying to understand, those tumors do not respond as well to the immunotherapy.
Yeah, and I think that's an important point to make, because targeted therapies, from what we know right now, and people who have those driver mutations, such as the few examples that you gave, don't typically respond. And what you said, I think that's most important, is we don't know why yet.
We don't. We're actively working on it, but clearly something is different about the tumor and the way the tumor is interacting with the immune system in some patients versus others. And we can kind of classify them, smokers on one side and high PD-L1, high stop signs on another, and drivers in the difference, but we don't really understand why that is completely, and actively working on that.
Yeah. And we're going to get into clinical trials and research and all that stuff in a little bit. So is immunotherapy used? Well, let me step back. You guys have also heard a lot in the last couple of years about new advancements made in early stage lung cancer. surgical patients, people who qualify for lung cancer surgery for a multitude of reasons. And if you want to know what those are, we just did a lung cancer living room on surgery and lung cancer not that long ago, but a lot of advancements have been made in the pre and or post surgical treatment areas, which we call neoadjuvant and adjuvant, so before and after surgery. Historically, even people who were surgical candidates whose lung cancers were found at an early age, the recurrence rate was relatively high, or way higher than we'd like it to be. So a lot of advancements have been made in this early stage. So can we talk a little bit about immunotherapy's use in an early stage patient? And I guess let's start with the non-small cell space.
So when we first learned about immunotherapies, we were learning about them in the context of what we consider stage 4 metastatic advanced stage. But what we've come to learn later is that they're also very useful therapies in what we call early stage. And these are cases where you can treat for a shot at a cure with surgery or radiation, where the tumor is in a single spot or a very limited region, and you can go in and try to remove everything. In those cases, what we want to do is we want to make sure that nothing is hiding. Nothing's hiding outside the surgery, nothing's hiding outside that radiation field. For many, many years, we've been giving chemotherapy to patients with tumors like this, and that chemotherapy has provided a benefit. The patients are less likely for the tumor to come back after the surgery if they get chemo either before or after, but usually after surgery or even with radiation. What we've discovered is immunotherapy really can dramatically benefit, again, some patients for the chance that surgery sticks, that the radiation sticks, that the tumor doesn't come back. It turns out when the tumor has kind of been knocked down, you cut out the bulk of it and there's just a little bit left, the immunotherapy can really go in and do a lot of work. So in almost all cases, we'll discuss using immunotherapy, even with chemotherapy, before surgery or after surgery, or certainly after a course of radiation for advanced cases. So, the details get a little complicated, but it's become basically, for most patients, a very standard part of the treatment now, for even early stage. Now, I'll stop for the question now.
Yeah. Just to clarify, are you speaking of folks with target mutations as well as other folks like with lung cancer, with smoking history? That's
exactly the right question. So that's where it's sort of the discussion, is it the right thing or not? So for patients with the driver mutations, we tend not to go down the immunotherapy road, we tend to go down the targeted therapy road, and that's the emerging treatment paradigm for these patients, is they'll get targeted therapy after surgery. But if you don't have that targeted therapy, then we're looking down the immunotherapy road. And those patients, again, it's about who's going to respond better, who's going to get the best benefit from this treatment. And the patients without the drivers are going to get the most benefit.
And I think this is, not to interrupt, and I want you to stay sort of in this vein, but this is why you hear us all the time pushing the importance of this comprehensive biomarker testing, right? So that your healthcare team can personalize as best they can what might work best for you. So in the case of somebody who does have a driver mutation or qualifies for a targeted therapy, that might be the right thing. And if you don't have it, then they're looking at, is immunotherapy appropriate?
I'm sorry, I just didn't clarify that my question was for early stage folks, stage 1 and 2, this is still the case.
That's absolutely. So for my patients, for all patients, almost regardless of stage, even my stage 1As, I like this information, even the tiniest little tumor. I want to know what the mutations are. I want to know what the expression of that PD-L1 marker is. I want to know how many mutations are in the tumor. I want to know all this information before I can sit down and talk to them and be like, these are our options. These are the risks and benefits of those, and this is what we should pursue. So everybody's getting that profiling, at least in my clinic, everybody's getting that profiling because I think it's so important for decision making at stage 1, 2, 3, and 4.
This is a really was not necessarily slated to talk about it, but you brought it up, so I'd like sort of your opinion a little bit further on this. So right now, the guidelines, the NCCN guidelines, are recommending for those that it's appropriate for immunotherapies for stage 2 and above, but not necessarily the 1As. And we do get a lot of questions from people who are, in that category about whether or not they should have biomarker testing and whether or not they should be having treatment.
So biomarker testing, I personally think, is an easy one. There's no reason not to do biomarker testing. It's not that expensive. It's certainly not harmful to the patient, and it gives me information, and who knows what's going to happen. Maybe that information will be helpful. I'd always rather have more information than less. Now, treatment, that's a very personal, complicated question. The guidelines do say stage 1A. The very tiny little tumors don't necessarily need treatment, but what we've seen is some stage 1As are no big deal, and 90% of them, no, the tumor never comes back. So it's hard to add treatment on when treatments have side effects, when there's a 90% chance of a cure already. But some stage 1As are only 60% chance of cure. That's a big difference. So we've been really working hard with our surgical colleagues to figure out who are going to be the 60%, and who's the 90%, and let's escalate the treatment on those tumors where there's a substantial chance the tumor will come back, because I can make a meaningful impact on those patients.
Yeah, and I think you just said something about your surgical colleagues, and I think it's an important time to maybe interject the importance of these multidisciplinary sort of conversations, regardless of stage.
Yeah. So all surgical cases are all presented at a tumor board, which is a multidisciplinary meeting. So surgeons are there, imaging's there, our radiologists, our pathologists who review the surgical findings, our radiation oncologists who can do radiation to help clean up anything post-surgically, and the medical oncologists who can provide immunotherapy, targeted therapy, chemotherapy. So we all sit down and discuss each surgical case, and we say, this is what we think we should do. And then we get a chance to meet with the patient and kind of relay the results. And I think that should also be very standard for any case, because this is how we're going to cure more of these cases, by taking a multidisciplinary, multi-pronged approach to treatment.
Jennifer, yeah.
I'm just curious, from the way I understand it, you're saying that for somebody that, for like in my instance, stage 4 EGFR exon 20, I had a low PDL 31 to 40, but I was treated with immunotherapy after chemotherapy. And from what I understand, you're saying that that's not even something that would be considered as part of the first line treatment or part of the treatment?
So the jump from early stage to late stage to the stage 4, I would say that I would not use a checkpoint inhibitor as my first treatment, as an immunotherapy, as my first treatment. But later down the line, absolutely, because maybe it's not the most likely to work, but it doesn't mean it won't work. So I start with what's most likely to work, what's going to give me my most benefit, and then I move on to what's my next most likely. So it's not that patients with EGFR mutations don't respond. It's that they tend not to respond early. So the first treatment, it tends not to work. They tend not to respond after surgery or before surgery. But later on in a treatment course, we do see really good responses. And I've seen it too. It's not as well studied. I can't tell you, there's 100 patients and 24% respond. But it's absolutely something all of us use in our treatment, because it's a great option. And if it works, it can be amazing. And so we always want to shoot for that chance, but it's not first.
I think you make a really good point, and I think one of the examples I've used before, especially early in the targeted therapy days, particularly around EGFR, was when the early studies came out and EGFR was first approved, there was, based on the studies and who these studies were being done on, the recommendation was Asian, females are more likely to have an EGFR mutation than any other population, based on the sort of the OG science, right? And we've come so much farther than that now to better understand EGFR. And I think immunotherapy really, I don't want to say it's in its infancy, and it's probably not even a toddler. It's like maybe a middle schooler, right? When we're thinking about about how long it's really been around and what we really know about it. And we are going to talk about research in a little bit, but I think, and the importance of research and why it's important that people participate, why it's important that people have these conversations with their healthcare providers, because I think there's so much misunderstanding. I guess there's just so many nuances.
It gets complicated. You know, some things are simple,
Yeah.
and some things are complicated. So the general picture, there's targeted therapies, there's immunotherapies, and they're separate. That's simple. But the reality is that everything's kind of in between, and where you start on one side, you can end up in another.
Does anybody else have any questions before I do want to jump into immunotherapy and its use in late stage?
Sure.
It's not all that. Well, I'm going to go ahead and let you.
No,
say
yeah, that's so. Immunotherapy in the late stage is, for the majority of patients, is going to be the first part of their treatment. Okay, so if you come in and as a late stage patient, you absolutely must have molecular sequencing and a PD-L1 testing done. This is just 100% required, because it very much dictates what the primary treatment is. Remember, in early stage, the primary treatment is still surgery, it's still radiation. We're doing stuff to help the surgery and radiation really stick. In metastatic, the medicines are really what's going to help us get our control over this tumor. So patients with targeted therapies should go down the targeted road. If you have an EGFR mutation, a canonical one, you should be taking Tagrisso. If you don't have one of these mutations, that's when we start talking about immunotherapy. And this is where it can get a little complicated. Some patients could get immunotherapy only. Some patients could get immunotherapy and chemotherapy. And some patients could get a more powerful, I call it immunotherapy. It's 2 immunotherapies at once. And there, it's really a very personal decision. It depends on how high those stop sign markers are. Are they really high, or are they just kind of high? And that's something that's graded on a 0 to 100% scale. Depends on how big the tumor is, where you are with your life, what do you want? And so it's a decision you can make with your oncologist. I would say in general, we're combining chemotherapy and immunotherapy together as the frontline regimen for newly diagnosed non-small cell lung cancer without driver mutations. That doesn't mean everybody gets that. And it's a personal decision, which again takes into account the tumor and the patient.
So, how important is shared decision making to you when you're working with, talking with your patients about treatment options?
I think it's extremely important. I always will present what I think are the reasonable options. And, it can be simple in the front line. It can be, like I talked about, those 3 options. And second line, it can be more complicated. We can talking about trials. We can talking about, things that are off-label. But there's always a balance. There's always a risk versus a benefit that you have to talk about. And it's never one size fits all. So I will always present at least 3 or 4 options to a patient, and we will discuss them and see what they want to do. I think that's the way to practice. It's sort of the way we're trained these days, and I think it's the way patients want their physicians to be. But you guys can tell me if you don't like it.
So when thinking about immunotherapy, there was 1, then there was 2, then there was 3. How do you determine which type of immunotherapy might be right for an individual?
Big picture-wise, there's only 2. There's a special one for small cell we'll ignore for now. There's only really 2 immunotherapies. Just one of them has a lot of different names. There's the PD-1, PD-L1 inhibitors, like I said, Keytruda, Tecentriq, and Imfinzi. To me, and unless anybody creates any new data, they're all the same. They have different approvals for different indications, but there's no real difference in those drugs as far as we're aware. So I would just say there's a bucket, and the PD-1 inhibitors are in that bucket. And I can pull any one of them out depending on what the FDA approval is, but I expect them all to work the same. There's a second bucket, which is actually the first one discovered, the first one in the clinic, but really the second one we use. That's the CTLA-4 inhibitors. The names don't matter as much. It's got a funny name. It's called ipilimumab, which takes a long time to learn how to pronounce. So it works in a very different way. It's not a PD-1 inhibitor. It doesn't block the stop signs. It acts in a completely different manner. And it is an approved immunotherapy in combination with the PD-1 inhibitor and a little bit of chemo for first newly diagnosed lung cancer. The combination, I always say, is more powerful, more toxic. And we'll talk about toxicities later today, but it's an important topic. That combination is something that you should talk carefully about your physician with. Is that something I want? Do I want to be aggressive and take that risk, or is that too much for me today? I think that was your question.
Yeah, I think that was my question. Michelle, I just want to do a quick check-in with you. You guys are okay online? I've scribbled notes all over this. How do you choose? Blah, blah, blah. I have a question. So how do people receive this type of therapy? We talk a lot about the pills and targeted therapy. How is immunotherapy administered?
So it's a lot like chemo in some ways, and it's very different than chemo in other ways. So when we give immunotherapy at UCSF, you'll come in, you'll get your blood work checked, you'll talk to one of our team members, either a nurse practitioner or a physician. They'll check in on you, see how you're doing. You'll head off to the infusion center, you'll have an IV started, and you'll get an IV, and just a bag will drip into you. It's pretty quick, though. It doesn't take hours. It runs quickly, and then they'll unhook the bag, and they'll send you home, and you'll feel no different. Unlike chemo, there's no immediate sort of side effects. But all the immunotherapies right now are being given by IV infusion. It's not that they will always have to be given by IV infusion, and there may be ways to develop immunotherapy where it doesn't have to be, but for now, they're all IVs. But just because they're given like chemo doesn't mean it's a chemo-like drug. I want to be clear that what you'll feel as a patient when this drug is completely different than what you'll feel with chemotherapy.
Yeah, I think that's a relevant point. And what about longevity? How long are people expected, or how long do people typically stay on immunotherapies?
So this is the real other than the side effects, the real other difference with the immunotherapy is the duration of response. So I'm not saying the number of people respond, but I'm saying if you're one of the people whose tumor really responds, how long is that response? That's where it's really changed the way we think about lung cancer. With chemo, it was always, we're giving chemo, and eventually the tumor will become resistant, and we'll stop, and we'll switch to a new chemo, and the tumor will become resistant. And we can keep that going. We can control the tumor. We can take breaks, and we've spent years working on this. With immunotherapy, what we've seen in a subset of patients is that we'll give the treatment sometimes as infrequently as every 6 weeks, and we'll give it for 2 years, and we'll stop, and we'll just take a long break. And I think every physician out there has stories of patients who've been on immunotherapy, took their 2 years of treatment, and then have come off and haven't had a touch of medicine since, even though they were stage 4. This is why we're excited by it. Now, that is not everybody, and why some patients' tumors respond that well and others don't. We're still trying to understand. The checkpoint, that PD-L1 marker, is the number one predictive sign, but it's not everything. So 2 years is the typical maximum duration, but typically we would treat until then and stop.
Okay. Yeah, we have heard of these sort of miraculous responses of people being off of their immunotherapies with no new evidence of disease. And similarly, we've seen it in targeted therapies as well. And the key is, again, the science and the research to identify and unlock what is it about X, Y, or Z person's, the cancer that is allowing that behavior.
Yeah, it's clearly some cancers are going to respond really well and some don't. And we have no way of predicting really what tumor that's going to be on day 0. You come see me after 365 days, I can probably tell you this one's going to do really well, and obviously it didn't. Yeah. But just a priori knowledge, we're not good at that yet.
Yeah. I want to jump into small cell now, because as a lot of you in this room, again, and those who watch online have heard me say in the past, small cell lung cancer, I don't want to say was ignored, but from a research standpoint, was ignored for decades, and some really exciting things have been happening in the last few years. So can we talk a little bit about small cell lung cancer and when immunotherapy is used to treat it?
Sure. So small cell lung cancer is sort of the lesser known, sometimes worse acting brother of the non-small cell lung cancer. Maybe 1 out of every 10, 1 out of every 5 cases of lung cancer is actually small cell. For years, the treatment was very, very aggressive chemotherapy, maybe radiation therapy to the brain or to the lungs, and then take a break and hope it sticks, but often it wouldn't, and the cancer would come back, and you've tried the chemo again, it's hard. Immunotherapy's really changed that. We use immunotherapy in both what we're going to call extensive stage and limited stage small cell, which I can explain. But in both cases, immunotherapy is part of the treatment plan these days. And again, this is not a driver of mutation cancer. So almost every patient now is getting immunotherapy who has small cell lung cancer. And again, it's changing in a subset of patients that long-term survival. It's helping that chemo stick. It's helping it control the tumor for very long time periods.
And I think one of the things that's so, again, important about this, and I'm going to reiterate it, is for so long there was sort of, it wasn't a one size that fit all, but it was just sort of a one size, right? Like everybody got the same treatment. Everybody, typically, not everybody, but the typical first line chemotherapy response was pretty good, and then not so much after that.
So yeah, small cell, we think of the textbook small cell case as a very aggressive, quickly growing tumor that you treat very quickly with chemotherapy, and it will melt away, and you'll feel great until it comes back. And that's what's changed with immunotherapy. So now what we will often give in advanced cases is we'll give the chemo with the immunotherapy right up front, and then we'll keep the immunotherapy going. In the earlier stage cases, after we finish the radiation and the chemo to truly treat the tumor everywhere again, we're going to consolidate our treatment, just like the non-small cells with that PD-1 inhibitor. It's the same idea of like cleaning everything up by stimulating the immune system to go in and find anything little hiding bit and go clean it out and take care of it. Because the immune system can do that much, much better than any chemo can, it turns out.
So you mentioned something earlier that I want to go back to, and it was the response of people who had a smoking history, being the response rates were higher. Small cell lung cancer is most often attributed to a smoking history, or there's a very close tie to smoking history, similar to some non-small cells, but small cell in particular. So can you explain that a little bit? Maybe does it have to do with what they call tumor mutation burden? What is that, first of all, and does it have anything to do with it?
So just to set the stage, right, our body is made out of cells. The cells are the little pieces of our body that are all doing their own jobs. The heart cells are beating, the liver cells are clearing out the wine we had for dinner. That's their job. They're told what to do based off of the DNA. The DNA is a molecule that encodes information that says you're a liver cell and you should, clean up after my eating, and you're a heart cell and you should beat. That code, that information can get damaged over time just by the process of living, just by dividing and replicating and growing and making new cells, just by damage done by environmental things. So some environmental things we don't have control over, some we do. Smoking can cause direct damage to the DNA. And by changing the DNA, it changes the instructions. And sometimes those instruction changes are meaningless and have no effect. And sometimes those changes cause the cells to stop being a heart cell, stop being a liver cell, and start being a cancer cell, something that's not you. What happens if you change the DNA is you change what the cell looks like. And if you change what the cell looks like, that means the immune system's going to say, whoa, that's not me. I would recognize myself. That mutation in the DNA, I'm going to attack that. I've never been trained. The immune system's trained on you. It's not trained on the tumor. So the more mutations from the smoking, the more chance there is for the immune system to attack the tumor, the more chance there is for the immunotherapy to rescue that immune response.
Yeah, that makes sense. Does that make sense to everybody? I think that was a really great way to explain it, because it's complicated. And I think, a lot of people now are going to Dr. Google to find their information and reading some of these big words and not really understanding them, and then not to mention sort of the emotional aspect of a diagnosis itself, but then going in and trying to understand what it is you're reading. So I really do appreciate the simplistic way that you're sharing this. So just to recap a little bit, immunotherapy drugs are used to treat both non-small cell and small cell, both limited and extensive stages 1 through 4 in non-small cell. The decision is made, and pardon me for reading, and this is chicken scratch. Your healthcare provider, along with you, will make these decisions, correct, based on the stage and type of the cancer, the timing of potential other treatments, and the ever important biomarker results, including PD-L1 testing. So in a sort of nutshell, at a very high level, that's how immunotherapy is.
Exactly right, yeah.
So we touched a little bit on, we didn't touch on it yet, but you mentioned it because I know you knew it was coming, side effect profiles.
This is, yeah, sorry.
No, go ahead.
I think this is very important to think about. If you get chemotherapy, I can kind of tell you what to expect. There's the nausea, the vomiting, the tiredness, the things that you find frustrating. I can tell you your blood counts are going to go low, and I'm going to be watching them, and I might need to give you a transfusion. I'm going to tell you you're going to get the medicine today, and you're not going to feel good in these 10 days, and you'll start to feel better on day 20, and then day 21 you'll see me again. We'll do it all over. I can explain that to you and with great detail, and there's some surety in knowing this. Immunotherapy is unpredictable when it comes to side effects. I will say most patients who get that PD-1 inhibitor do really, really well, okay, and are able to take it, and they say, oh, nothing happened. I felt nothing, or I felt just a little tired the next day. Most people don't even notice it. But there's a balance. The immune system, remember, it's trying to say, this is me, that's not me. Tumor's not me, let's go after it. Okay, it's a system. It's not perfect. It makes mistakes. So what it can do is it can start recognizing yourself as not self, okay? So my skin, it says, well, I'm not sure about this skin, okay? And you'll get a rash, okay? Very common. Or itchy skin, very common side effects. Now, if it's just a rash, it's annoying, but it's not a really, really big problem. But imagine that's your heart or your liver or your lungs, okay? So I always tell my patients, take your finger and point to anywhere in your body. The immune system could attack that on this drug. Now, most patients won't have a problem. Most patients sail through this without a major issue. But there's always a risk of really severe side effects. And what I always tell my patients is it requires you to be vigilant. Things you would be surprised by can happen, okay? I've had patients who get diabetes from the immunotherapy. I've had patients who've had heart failure from immunotherapy. So when you're on the immunotherapy, you need to call your physician for anything that you might normally say, I'm not sure about this, because it just takes extra vigilance on everybody, because anything can happen.
Sorry, I'm writing this note, but yeah.
How does immunotherapy affect the kidneys?
So directly, it doesn't affect it at all, which is really nice, right? Unlike some chemos, it doesn't, and the kidney's not even really involved in the immunotherapy. But, like I said, I can point my finger to the kidney. So I've had patients who've had inflammation of the kidney from the immunotherapy. Now, if you have a side effect from immunotherapy, that's not the end of the game, okay? 1, stop the medicine. Usually the symptoms go away. 2, we can turn the immune system down a little bit. So we can add on a steroid or other types of drugs, which just turn it down. And if we give you a little break, and a lot of times we can give you the immunotherapy back and you won't have the side effects back, okay? So typically the side effects are the rare side effects, the serious ones are very rare. The mild side effects are much more common, but usually kind of survivable, livable. And then we can usually reverse, not always, but we can usually reverse the bad side effects. And it doesn't mean the end of the treatment.
I think this is important, though, and you guys have also you've heard me say so many things over and over, but yeah. Let's grab you a mic. And I'm just going to make this really quick point, but it's why it's so important that you all are reporting any side effects to your healthcare team when they happen. I know quite often people might be a little anxious about reporting them because they're like, oh boy, if I tell my doc this, they're going to take me off, a drug that is potentially working really, really well for me. Yeah.
So, doctor, does any of this can go to the brain? Obviously not. What happens when it's metastasizes? Mine has to the brain. So there's not any. I'm EGFR, so stage 4.
I understand. The immunotherapies are active against brain cancer, against the cancer that's spread to the brain. So the antibody is able to the drug is able to get into the brain and act there and stimulate immune responses in the brain. So there's no contraindication. There's no reason not to take immunotherapy because you have brain metastases, and there's no reason to think it wouldn't work. Now, every case is different, of course. But unlike the pills, like the EGFR, we worry a lot less about how much is getting in the brain. For the chemos and the pills, it's always like, how much did it get in there? Did we get, if I give you 80 milligrams, do you get 10 milligrams in the brain or 20? Those are not things we have to worry about with immunotherapy because of the way it works and the way the immune system can kind of get everywhere. We don't need to, those are less of an issue.
You mentioned something earlier, and I'm super curious about this, and we're about to get into some of the exciting things maybe happening in research right now in the immunotherapy space, and maybe this is one of them, so tell me to zip it and I'll let you talk. But for folks who maybe have been on a TKI or a targeted therapy that is no longer working, and they're on first, second, third, fourth line, you said we might try an immunotherapy on said person. What does that look like, and how do you make that decision?
So when I have a patient who's got a molecular target, I like to exhaust that molecular target. I like to go after as much as possible. So that means the standard frontline regimen. That means any second-line regimen that's out there if I can find one. That means a clinical trial if I can find one. Just being continuously looking at the tumor, looking how it's evolving. That's how I think about it. But that doesn't always work forever. At some point, we may need to switch to something else. So when you lose your targeted therapies, you're talking chemo and immunotherapy. So I always think, well, why not? Why not give them a chance at that? So I will commonly give that combination to patients after the targeted therapies are just not an option anymore. And if 5-10% of those patients get a good benefit from the Keytruda or the PD-1 inhibitor, that's great. I mean, sure, it's not as good as I would expect as a patient coming off the street who's a heavy smoker and this is their first treatment, but it's still better than zero, and the side effects are generally pretty good. So I always consider it in those cases. And if we get a benefit, great. If we don't, well, we move on to the next thing. We escalate the immunotherapies. We try different chemos. We're always thinking, what else is there out there?
No.
You've talked about each of the different targeted diagnoses. I'm BRAF positive and negative, and there don't seem to be much in the way of clinical trials, or is it about 10% of the population, the lung cancer population, that's BRAF?
So the BRAF mutants, especially the V600E and around the hotspot, I would say it's closer to a few percentage. It's probably a lot less than 10. But, and I should have mentioned this before, not all targeted mutations are the same. So there's the classic ones. There's our EGFRs, our ALKs, our ROS1s, and then there's our newer ones, and ones maybe haven't talked about as much. KRAS, I don't know if we've talked about KRAS. So KRAS, BRAF, MET. For some reason, again, a little bit of a mystery, those tumors can do really well in immunotherapy. So even within targeted therapies, it's not clear. Now still, if you have targeted therapy, I'm going after the target. But I expect more of a response in a patient with a KRAS mutation, or a patient with a BRAF mutation, or a patient with a tumor, who has a MET exon 14 skip mutation. I expect better responses. I don't know why. I'm just saying, this is our history, this is our experience. But understanding at a scientific molecular level is missing completely.
Okay.
I think this is what's exciting about the research, though, right? And why I said we're maybe not in its infancy or toddler stage, but I think there's so much more to uncover and open up when it comes to unlocking your body's own immune response to something that doesn't belong there. And we talked about, which kind of brings me to this next question. We talked about DNA damage, actually damaging the DNA. And we know that particularly people with a heavy smoking history can actually damage their DNA. But is it just smoking? Can DNA be damaged by extensive exposure to pollutions or chemicals or any of that?
So absolutely, and the radiation exposure, certain chemicals and benzenes and things like that can absolutely cause these things. So a lot of patients will have had toxic exposures in their life. They'd, even for lung cancer, they worked in the shipyards here and they were exposed to asbestos. And we talked about the mesothelioma, it was certainly related to lung cancer. We're born as we're born, and then after that, we are just the summation of what happened after, including our experiences and just what I call just random chance. Now, random chance dominates, but experiences manipulate those odds.
Yeah, really important. Michelle, I'm checking in really quick before I go to research. I'm also trying to be really mindful of time. So, huh? Oh, yeah, you need a mic, sorry.
What would you suggest to people that are watching right now that may not have the opportunity to be where we live currently and have access to amazing academic centers, and were diagnosed maybe 2 months ago and they have never heard of immunotherapy, they have never heard of targeted therapy? What would you suggest that they go back to their doctor and ask? I was watching something and heard about this and X, Y, and Z.
So, one, I think every patient at diagnosis should hear that there are 3 types of treatment for lung cancer. There's chemotherapy, immunotherapy, and targeted therapies, and that's the wells we're going to be digging in to treat this cancer. I think that should be part of every patient's first visit, especially for stage 4. And I encourage anybody, within the state of California, you can hop on a Zoom visit and see anybody at Stanford, UCSF, UC Davis, any of us. We're happy to see you guys anytime. Even if you just want to come by once and just chat, it's always happy to do that. You don't even have to drive all the way from wherever to this middle of the city. And any physician should be happy to send their patient off for just a second opinion, just to talk. I think if a patient, especially if they haven't heard of a driver or of a targeted or immunotherapy, they should be talking to their doctor, be like, what's going on here? What does my tumor look like? Do I have mutations in my tumor? What's my PD-L1? Why am I on the treatment I'm on? That should be something they understand, and that's a very important thing to do. So if they don't understand it from their doctor, they should talk to other.
Yeah, I think it's a really relevant point. GO2, as you guys know, we have a helpline, and so we talk to folks from all over the country and even outside of the country who have questions like this. And to your question and to your point, as much as we'd like to believe those conversations are happening absolutely everywhere, we know that they're not. And even if it's a small percentage of, the people diagnosed, it's 100% of that small percentage. And that's just, it's not acceptable. So I think it's a great question, but I also want to throw out that we are here, and for those watching online, I'm sure the helpline number is going to come up on the screen about now, and it's a toll-free number where we can help you get access to, Dr. Allen's point, if you're in California, we can help refer you for a second opinion somewhere else. These second opinion docs are more than happy to work with the docs local to you on a treatment plan that is best for you. So I think it's a really important point. Okay, research.
So yeah, I think immunotherapy is extremely exciting because in that set of patients who've done so well, we've seen it with targeted therapies, but to this number of patients, to this extent, I think this is really new. I think of the way we treated lung cancer in terms of kind of epochs. There was like the chemotherapy, which started being developed in the early part of the 20th century, really got perfected in the 1990s. And since the 90s, really hasn't been much new in the way of chemotherapy. And honestly, I don't think there will be much new in terms of chemotherapy. Chemotherapy is a toxin, and you can only make a toxin so tolerable for a patient without being toxic for cancer. And then, in the 2000s, we had targeted therapy. And, I think we've really started to perfect targeted therapy. There's a lot more to learn there. But I think we've made a lot of progress. So the 90s, and then we got 2000s. And 2010s, that's when immunotherapy came out. So we had all the PD-1 inhibitors. Ipilimumab was the first one. And we've really learned how to really apply those, in this decade to early stage and to basically almost every late stage case at this point. I think what's coming next is a combination of those last two. I think, that drug I referenced in small cell is a good example. So that drug's called tarlatamab. It's probably, I don't know if we've ever heard it. We discussed this one here?
We've discussed it, yes, prior to its approval, and we have a very special small cell, but yes, please go.
Sure. So the reason tarlatamab is so exciting is because it pushes immunotherapy beyond where it normally is, okay? Immunotherapy relies on the immune system. It relies on how it was trained. The immune system was trained to say, again, this is me, that's not me, okay? And that training is doing okay, but clearly failed. The tumor's there. We're giving it a boost with the checkpoint inhibitors. What these new immunotherapies doing is they're retraining the immune system. They're not relying on the immune system to know what a cancer is. It's telling the immune system this is cancer. So that drug in specific is called a T-cell engager, okay? And it's the first T-cell engager ever approved for any solid tumor, and it was approved for small cell, the first antibody-based one. And what it does is it says, I'm going to tell the T-cell this is a tumor, and because a tumor has a little marker on the outside of it. That marker, the name's whatever, DLL3, but that's just the name. Okay, so there's a marker on there, some little flag, and it says, all right, if you see the flag, this is a glue, and it glues the flag to the immune cell that kills the tumor. Glues them together. The T cell says, oh, all right, I can kill this thing. I'm a T cell. That's what I do. I kill cancer cells. You gave me all the information I needed. We've retrained the immune system. And so this is targeted. It works for DLL3. It works for this target. But it's an immunotherapy. And this is the future, okay? This is what I work on in my lab. My lab is a cell therapy lab. We literally take the immune cells out of the body. We change their instructions. We give them new DNA, new information. We give them back to the patient with this new information to how to fight the cancer. So again, this idea of a targeted approach with immunotherapy by re-engineering the immune system, this is honestly what I think we're going to be talking about in the 2030s. When we talk about the next kind of epoch in how to treat lung cancer.
It really is incredibly exciting and feels very sci-fi futuristic when thinking about medicine. I mean, it really does. But tarlatamab also, I mean, since we're talking about it, and it was approved in small cell, but administration, there's a unique sort of process.
These re-engineered the immune system, it's early days, okay? When we re-engineer the immune system, we can overdo it a little bit, okay? You guys, I'm sure everybody here has had the flu and knows what that feels like, and that's can it be like. It can be the worst flu you've ever had, and you can feel that. And we're trying to learn how to balance that. So when you get the tarlatamab, you actually have to come into the hospital and spend the day there just to make sure you're not going to have a really bad flu, which means you need maybe some fluids, maybe some IV fluids, or maybe you need to be just watched very closely because you have fevers and things like that. So that balance we're learning right now, I think everybody is kind of, let's put our feet on the gas. Let's really give the immune system what it needs to fight the cancer. Then we're going to say, okay, let's back it off a little bit, and then let's get this safely. So very exciting, but still a lot to be learned.
Still a lot to be learned, yeah. And for those watching, Michelle, don't quote, I don't know when our small cell, March 18th. And we're going to be digging a little bit deeper into all things small cell, including tarlatamab, which I think you guys have heard us talk about and our excitement behind. And we talked a little bit earlier about our healthcare delivery team, and they're working very closely, particularly with the community centers, to make sure they're prepared to be up and running to provide this type of therapy to folks that live in their community because of at least the first. It's the first.
Yeah, and you'll hear about it more next month.
Yeah.
It's actually, I think they're being very cautious with the observation.
Yeah.
I honestly think the side effect profile in the trial wasn't that bad.
Yeah.
But this is the first one, and they don't want this to go poorly because, again, we think this is going to be a whole new class of
Game
treatment.
changing. Yeah, yeah. Love it, I love it, I love it. And that sort of, I guess, answers my very last question, which is really just what's most exciting to you. But I think you answered it about where it's going.
No, I just to reiterate, it's this idea that we can start programming the immune system, and we're good at programming stuff. We've been doing that for a long time, and our ability to now program the immune system is going to change our ability to fight cancer. So we will see what the next 10 years holds, but I'm excited to work on it.
Yeah, I love it. I love it. I can't wait to have you back and hear about where some of that research is going. Before I close up, does anybody have any questions? No? Good. What do you most hope people take away from this meeting?
I want people to be aware that what immunotherapy is, okay? It's something that can be very effective and something that almost everybody, unless there's a good clinical reason not to, should try and should be part of their treatment. And I want them to understand that, this is the first, I think, of many types of ways of using the immune system, and this will evolve and change.
Yeah, I think that's great. Thank you so much for coming and talking with us. Yeah, please. I do want to remind everybody that our next Gathering Hope is March 11th at 5:30. Our very own Michelle Zay, I think, will be calling in from DC. So for those of you watching who are our East Coast family, she will be on your coast during the next Gathering Hope, and I'm actually hoping to be able to join as well. Our next living room is March 18th. If I'd looked down 2 lines, I wouldn't have had to ask you, on small cell lung cancer in the treatment landscape. And we've got Dr. Carl Gake coming from MD Anderson. He will be joining us virtually to have this conversation. So we're real excited to have him. He too has never been here, so we're thrilled to be welcoming him to this programming. I want to give you a huge thank you again to Dr. Allen. I keep wanting to say Gary Allen because he's one of my favorite country artists, but definitely Dr. Greg Allen from UCSF. We hope you will come back and talk to us again about immunotherapy or anything else exciting that's cracking in lung cancer. Obviously, all of you in the room, those of you watching live and post-live, thank you so much to Penn Media for coming in here and setting all of this stuff up every month so that we can bring this to you all live and in real time. And then, of course, our very own go-tos, James Hall, who I know a lot of you locals know who James Hall, who does all of his magic in the background and edits this down, takes out all my ums and weird things that I might say. A huge thank you to James as well. And obviously Michelle, who I've already called out a couple times, and I know how comfortable she is when I call her out and everybody in the room turns around and looks at her. But I would be remiss in not thanking our supporters. So Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Daiici Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda Oncology. Thank you so much for your support of this programming. And Jackie, you're holding a mic. Do you have one more question? Or you're just holding it because it's comfortable? Ooh. Thank you all. Have a good night. Jackie, you can still ask your question.
So I'll be brave if you're brave. I'll be brave, but only